Okay, class, we're going to continue talking about the conduction system of the heart. So we've learned about anatomy and physiology of our heart and some of the different structures of the heart, and now we're going to be focusing on that conduction system. So the conduction system of the heart normally will start in the SA node, the sinus node. We refer to it as the SA node because it's a sinoatrial node, and it's located right here in the upper right atrium where the superior vena cava and the right atrium connect. That is the normal pacemaker of the heart because it normally fires at the fastest rate. Whatever is firing the fastest, that's what's going to pace the heart. And that should normally be the sinus node. Now we'll be learning as we go through this class about times when the AV junction can take over due to irritability, or the atrial pathways can get irritated, or the ventricles can become irritated and fire faster than what the SA node is firing at and take over. But normally it should be that sinus node. The sinus node normally fires at 60 to 100 beats per minute, which that's why that's our normal adult range is 60 to 100. And when I talk about that normal range, that is an adult range. The sinus node, what it's going to do is it's going to cause the impulse. It has automaticity, so it has the ability to automatically generate an impulse, and it has conductivity. It's going to conduct it through the pathways. And there's intraatrial pathways and intranodal pathways. And so it's going to send that impulse through the intraatrial, the intranodal pathways to depolarize the atria, to let the atria have the entire stimulus get through to it. And then when it gets to the AV node, the AV node's actually going to hold that impulse for about 0.08 seconds to allow the atria actually time to contract in response to that depolarization. So when the sinus node fires and it sends that impulse through the atria, that is going to give us our first waveform, our P wave, on our ECG paper. That is telling us the atria depolarized. The atria got the message. We're hoping contraction followed it. From the AV node, it's going to go through what we call the bundle of His, and then it's going to bifurcate down the right bundle branch and the left bundle branch. Now, the left bundle branch actually has a couple fascicles to it, so it usually goes down the left side a little bit quicker than what it does the right side. And then the last part of the conduction strands are these Purkinje fibers in the ventricles, and that's going to help depolarize all those cells in the ventricles. So normally we said it starts with the SA node, travels through the intraatrial and intranodal pathways to the AV node. Now, the other thing that can happen is if for some reason the SA node doesn't fire, the SA node loses that ability for some reason. The AV node plus this bundle of His right here is known as the AV junction. And you have pacing cells right here in the junction area right next to the node. And the junction can actually pace the heart for you. It can either do it as a backup system because the SA node failed to fire. And if the AV junction fires as a backup rate, the rate's only 40 to 60 because it's slower normally than what the SA node would be. There are times, though, that it can become irritated and fire faster than that just to take over. The other part that's really cool about the conduction system are these ventricles, the Purkinje fibers of the ventricles. They also have some ability to have automaticity. And so let's say you had a heart attack and the person, it wiped out their sinus node, it wiped out the AV junction, and nothing's kicking in. Your Purkinje fibers can actually fire for the heart as a backup system. Now, as a backup system, it's only going to be a rate of 15 to 40. Well, some books say 20 to 40, some 15 to 40, but it's really slow, okay? Which isn't anything to write home about, but if it didn't kick in, then we wouldn't have anything pacing the heart, which would, of course, be detrimental. So when we're looking at our waveforms on ECG paper, that first waveform we see is going to be the P wave. The P wave is telling you that the atria have depolarized. Now, if the atria have depolarized and they do it in a nice, normal, rhythmic fashion from the sinus node itself, that P wave will be rounded, symmetrical, and the same going all the way across our strip. So the P wave tells us the atria have depolarized. A nice, normal, rounded P wave is going to let us know that it came from the sinus node. Then we said the AV node holds it for about 0.08 seconds to allow the atria actually time to contract. And then it's going to get to the ventricles. It's going to go down that bundle of His, down the right and left bundles, to depolarize the ventricles. When the ventricles depolarize, that's going to give us our QRS complex. Then our ventricles have to recover. And so when the ventricles recover, right after the QRS, it should go flat. The ST segment should go flat or isoelectric. And then you would have your T wave. And the T wave is letting you know that the ventricles are recovering. Now, the reason we don't see a waveform after, when the atria recover is the atria are recovering right about the same time the ventricles are depolarizing. And the ventricles, since they're such a large muscle mass, that's what's going to take priority. That's what we're going to end up seeing. So we have this electrical process. And so when we look at ECGs, it tells us what the electrical process of the heart is. The electrical charges in the cardiac cells. And they're provided generally by two chemicals, your sodium and your potassium. And it's these shifting of the ions in and out of the cells that allow the electrical impulses to travel. So we generally have three electrical states. There's what we call polarization, where the cells are at rest. There's no electrical activity being generated, but everything's ready for action. Everything's ready to go. So potassium is usually inside the cells and sodium is usually outside the cells. Then depolarization happens. That SA node fires, it causes that electrical stimulus, and it starts causing those sodium and potassium ions to start shifting, sending the electrical impulse down the cells. So that's going to actually get that message to travel through the heart. And then repolarization is when the cell has to get back to its resting state before it can accept another impulse and do the whole process over again. So electrically, when the SA node fires and it sends that impulse through the atria, it's going to give us our P wave. Again, P wave tells us the atria have depolarized. If it's a nice normal rounded P wave that looks the same going across our strip, we know that impulse originated from the sinus node. The QRS, so basically what's happening is the SA node fires, travels through the atria, gives us our P wave. What's happening mechanically is the tricuspid and bicuspid valves open and blood drops down into the ventricles. So 70% of your ventricular filling is just when those valves open and blood drops down into them. Then when the atria hopefully contract in response to that stimulus, it's going to push that other 30% down. And that's a lot of times known as our atrial kick. Then the impulse is going to travel past, it goes through the AV junction, it goes down the right and left bundles, and that gives us our QRS waveform. That is telling us the ventricles have depolarized. Contraction should happen immediately after. And so what's happening is now our tricuspid and mitral valves close, our pulmonic and aortic open, and the ventricles contract, and we have systole. And then the ventricles repolarize. It's going to give us our ST segment, which should be flat, and then our T wave. And what's happening here is now blood's filling back into the atria, the ventricles are getting back to rest, so we can start that whole process over again. So we're going to stop here and take just a short little break, and then we will continue.